Hello, everyone, and welcome back to See the Invisible Living with an Invisible or Rare Disease. My name is Rhonda Franny Jefferson, and thank you so much for joining me today. If you're new here, welcome. To give you a little bit of information about myself and the podcast, I do have a rare and invisible illness. It took a number of years to diagnose, but by that time, a diagnosis was actually welcome because I didn't know what was going on, and frankly, even some of the doctors in the area probably thought um, I was exaggerating probably until an event happened where it was obvious that something was wrong. They just didn't know what to test for and how to find it. So, there were a lot of challenges then, and I've tried to learn to adapt and overcome those as best as possible. And especially during this past year and a half now, it's been more difficult. And, at some point, I wanted to start a podcast to try to be more positive, to let others out there who have a rare or invisible disease know that there are other people out there that may not be in the exact same situation, but at least, have an understanding of what it's like to face each day with, different challenges based on what illness you may have, as well as the increased challenges we have due to the pandemic. And whenever possible, too, I want to take a look at our caregivers and support system to, recognize what they may need from us to, help make it easier on them, like if they have to drive us to doctor's appointments or, just whatever the situation may be. And this kind of stemmed out of a comment someone made to me on Facebook that really upset me. And I didn't even know the person. They were a friend of a friend. And I decided to try to take that negative energy and turn it into something good. So here we are. We're approaching pretty close to a year of podcasts. And I've had to scale back a little bit just because of, some limitations that I'm having right now. But I do really enjoy sharing my story, and it honestly also helps serve as a therapy for myself as I'm able to, share some of my situations, experiences, and, hopefully bring something to someone that makes their day a little bit better. Now, we have been going over, just in the last episode, I started a series on healthcare disparities. And I'll just touch briefly upon what that is again, and then go into a few different points. Before I do any of that, though, I do want to just remind everyone that I am in no way a medical, insurance, or legal expert. If you do have any questions in those fields, please make sure that you're reaching out to the appropriate person to get that information. What I normally do is I review articles or papers that are online, and then provide my feedback or my understanding, as well as, whenever possible, give some examples from my life that may fall into that category as well. This is not meant to be any type of medical advice. As always, refer to your medical advisor. So, healthcare disparities. Now, I'd heard the term, I wasn't really sure what that meant entirely before. But, after looking at some research with some articles from asthma or about asthma, I saw that there was this huge, huge difference in the percentage of people that died from complications from asthma. And, as far as looking at race and gender, African American women were 5 times more likely to die from asthma or asthma-related complications than their white counterparts. And then going into it more deeply, there were also major differences in numbers regarding infant mortality. So even starting from the very beginning, there's a huge difference in numbers. And we're now, at the most advanced that society has ever been in regards to medication, medical practices, technology. So to have that much of a difference in the same country, and I will, in many cases, refer to the country as a community because we are. A lot of things within the country, we rely on the same thing, the same types of insurance plans, even if they're different, the same healthcare model in most places. So when I use the word community, I really am looking at the United States as a whole. So if you're not from the United States, I do apologize. I'm just not as familiar with the healthcare systems in other countries. But right now is the time to address these issues because these are things that have been known for years. And while things are getting better, they're not good enough yet. It's great to have objectives and goals, but those goals, if they're not moving forward, they're not doing much good. Now, one of the things I did start to touch upon was the healthcare baselines. And what I mean by that is basically a baseline is a starting point. So, as far as a whole baseline, meaning what should certain numbers be, whether it's checking your blood pressure, which I had my medical treatment this morning, and things were not really looking good for that. They almost weren't able to do that because of my blood pressure. Then, just the certain numbers you have whenever you have a blood test done, what is in the normal range and what is not. However, it's coming more, or there's more awareness that the numbers may not be the same for every race as well as between different genders. So it's the recognition first that yes, the numbers that most doctors look at to understand what the baseline of a person's health is may not be accurate to begin with. There's also your personal baseline, and if you do have a chronic or rare illness or any type of illness, that you do have to manage on a regular basis, you may even hear that your baseline might be a little different than others. So, I do go back to my experiences since they're the ones I'm most familiar with. When I was first diagnosed, my doctor was very straightforward with me, saying that there were certain lab tests that most likely would never be normal again, that they may come back normal once or twice, but never for any type of, sustained period of time. And she was right. Those same ones that she told me about, they're ones that I can't think of the last time I was in normal. And, some are actually getting worse, even with everything that the doctors are throwing at it to try to improve it. It's, just not working. But they can at least have an idea of, okay, this is where her numbers kind of stay in between. But if there's a big jump, we're going to have to do something drastically different. So that is the personal baseline. And you may want to ask, why are these numbers important? And for this information, I went to an article from Stanford, and in it, a Dr. Mary James was interviewed. And there's a couple quotes that I'm going to read from here, and they're more than one sentence, so they're a little bit long, but I'll start just to get more of the clinical term of baseline for an individual. And what Dr. James says is, your baseline has two basic components: existing illness and potential future illness. Your current baseline has been shaped by your medical, social, and family history and is constantly being influenced by common factors in everyday life. Although some components of your healthcare baseline are more modifiable than others, it is important to have an accurate understanding of your current health status. So, looking not only at your baseline, but also when we go into the broader aspect of disparities that people may have within the healthcare system, sometimes the individual illness, familiar background, how prone you may be to certain illnesses, that all comes into play with your baseline. It's also then, because it does affect your baseline, where your doctor really needs to know you and know your information so that he can make sure, or she can make sure, that you get the best possible care. Within, any type of system, there's always going to be some type of, I guess you would say, unfairness, in that when we're looking at the healthcare side of things, it, sometimes we may even step back and say, it's not fair that I have to deal with this illness, or that my loved one has to deal with this illness. But it's something that's there that has to be addressed. What that does is take our baseline and it moves it slightly to the left or to the right of where we really want to be. But it's something that we need to know so we can understand exactly how healthy we're staying. Now, in response to why it's important to know these personal baselines, again, to get into a more clinical term, not just the broad explanations that I'm giving, Dr. James again says, you may be thinking, I'm healthy, I take no medications, and never go to the doctor. Why should I start now? And there are two fundamental components to good health. They are appropriate treatment for current illness and appropriate preventative care to reduce health decline in the future. While most people actively seek care for the former, and as a reminder, the former is treatment for a current illness, she continues, we often forget about the latter. And, last week, I used an old saying that an ounce of prevention is worth a pound of cure. And that's going into a situation saying, okay, it's better if we do everything that we can to prevent something from happening, as compared to not taking those extra steps, not trying to get extra safety protocols in place. And then when something happens, we have to fix something rather than just prevent it from happening. On a more day-to-day basis, it could just be wearing your seatbelt and not wearing your seatbelt. Wearing your seatbelt is preventative care. And that way, if unfortunately you are in an accident, that seatbelt has helped mitigate the risk, where you either have really no injuries at all, or you have much fewer injuries than you would have had in the first place. So that's something I can really think of more as an individual. So having your baseline, you can look at things that might not be exactly right at the moment, keep an eye on them, or determine whether or not you need treatment. And as far as looking at your familial information, that's very important too, because it's not just you that you need to look at. You need to look at all of your different relatives. Now, at the beginning of this episode, I mentioned that it took a number of years to actually get my diagnosis. And during the whole time, we knew that my sister had an autoinflammatory illness. Going to my primary care physician, who was actually my mom's, my dad's, my aunt and uncle's primary care as well, they kind of knew the situation, even though my sister didn't go to them because she lived in another part of the state. We had still told her about that. So she and another person in her practice had actually run tests at different times for different autoinflammatory illnesses. And with some of the illnesses, it's more of a matter of elimination and taking some certain tests and putting it all together to come up with the diagnosis. But it still continued year over year. And about 50 weeks after my sister passed away from complications due to her illness, things were just getting really, really worse for me. And I ended up being hospitalized, which, when I went to the ER, sent there by my primary care doctor, they didn't really believe me. They were going to send me home. And at that point, I knew if I went home, I may not necessarily be able to make it back into a hospital if I needed to. So I stayed. My doctor said I was doing the right thing. And once something happened, my fever spiked up. They realized something was wrong, and I ended up being admitted. But still, after telling each doctor and nurse that I saw in the ER about my family background, including my sister, it just still was not recognized. It was only brought up again because I was in isolation and my father put on the gown that they give everybody who goes in there to visit. And he told the charge nurse when he gave it to him that the following week, by that point I'd been there for a while, so it was now 51 weeks. The following week would be the first anniversary of my sister's passing. And the doctor had happened to be in the room while all this was going on, and the nurse came in and said that to the doctor, and the doctor got this look on his face, and very emotional time. I started to cry, but it was also just very, very frustrating. If it hadn't been such a serious situation regarding my health, I may have just laughed over the fact that I had repeated things probably dozens of times by that point, and he looked like it was the first time he'd ever heard of it. And I'm pretty sure I said it to him too, but if not, it was definitely within my chart. And they narrowed down the focus, and I was then diagnosed with a rare autoinflammatory illness. After running a few more tests, one had to be sent to a outside lab, but that's what it came down to. So that's knowing your personal family health. And if you ever think that a doctor is not really taking that health seriously, especially when it comes, to something that's not as commonly understood, such as diabetes or blood pressure, make sure you speak up. I kind of learned that the hard way. I thought everybody was communicating, and they were not. So we should definitely repeat our assessments as we age. There are changes that take place, just as you grow older, and things that you need to check in with your primary care provider with, more than once over the course of your life. And before you really start any major changes in your life, whether it's a new healthcare routine or anything that might affect you physically, it's always a good idea to speak with your doctor. And during this interview, Dr. James did, have a quote that actually did kind of hit home for me. She said, talking about reassessing your baselines and, how you need to look at those. She said, some patients in their 80s and 90s led vibrant, more active and happy lives than many people decades younger. By establishing a baseline, patients can begin the process of preventing disease and taking preventative steps to achieve their goals in the future. So what she was saying there is that the patients if they take steps when they're younger, when they stay healthy when they're younger, then by the time they are in their 80s or 90s, they already have a good baseline. And so they have a better chance of either not developing certain illnesses, or if they do, they have a better chance of treating them better. Now, for example, my father is 87. He was diagnosed with cancer just before he turned 87. And what would have put most people half his age, myself included, my husband included, down for the count for months probably. He had 2 major surgeries in 3 days because they had to go back in after the surgery. And, he was up and he's out weeding the garden. He wants to cut his grass, and we're all telling him no. He also doesn't want to live with anybody because he's very independent and he's always been extremely active. And that's really what keeps him going. But without being that way throughout his life, he probably would not be able to bounce back the way he did now. So, yeah, like I said, he's 87, but probably people half his age would not have been able to bounce back as well as he did. Now, a big issue when it comes to baselines, when we're looking at the nation as a whole, for many, many decades, these baselines were based primarily on white males. Now, I'm not going to go bashing any group of people. Just, the white males who are here now had nothing to do with how the baselines were figured 70 years ago. But that is basically what it was. It was based on white males. And so now there's a better understanding that not everybody has the same numbers. Looking back to when I was a child, probably the first time I ever saw anything about this was when looking at a heart attack. There was a commercial I saw, and it was more of like a informational ad, and it was talking about how the symptoms for a heart attack are different in women than they are in men. But prior to really this recognition, if a woman were to go into the hospital and she wasn't having the typical feelings that most men would report, like the elephant sitting on the chest feel, it was not thought that it could be a heart attack. So it was recognizing that what the doctors had been told and trained for so many years was actually not quite right, that they had to retrain themselves to look at women when they came in with a whole new, different set of questions to try to determine if they were having a heart attack. And even up until more recently, I do know someone whose mother did go to the hospital with a lot of the symptoms for a woman who was having a heart attack, and they sent her home saying it was the flu, but she actually was back into the hospital within a couple of hours, and she eventually passed away because it was her heart. So, having years of that ingrained into doctors, they're thinking of their typical, symptoms that they were told while they were studying. And so, what they were told while they were studying is not their fault, but we just need to make sure that doctors understand that there are differences, to be familiar with the differences, to help, make an educated decision on how to treat somebody. And, I just personally, I think that, doctors every, 2 years or so need to go back in for just some very basic restudying, I would say, of things that may have changed, or things that were recognized since, they were in school. And if you have a more established doctor who, say, has been practicing for 30 years, just not only the advancements in healthcare that have been made since then, but also the understanding and recognition of some things have grown by leaps and bounds. So that's just kind of a general overview of why baselines are important. And what we're going to take a step into now are clinical trials. And, just a general idea of what a clinical trial is. Whenever a new treatment, a new procedure, anything like that is actually approved, it has to go through trials. So for those who have an illness that may possibly even be terminal, to get into a clinical trial could be a very big step into both their individual wellness as well as contributing to the future of this particular illness and their treatment. By being able to participate in a study that provides feedback. Now, usually within a medication type clinical trial, they give what's called a placebo, so it's basically just a plain pill. It's a control group, and that way, they can see, the doctors who are running it can see, what's the difference in outcome from the placebo, on the placebo versus the actual medication. A lot of times to get into these trials, you have to meet certain criteria. And depending on what the medication is, they may look at certain numbers from your blood work, look at blood pressures, things like that. And where that becomes a major issue is when different races or genders have different baselines to disqualify a group of people because they don't fall within those baselines is really short-cutting some of those people who will need the treatment for this illness. It's not including them into a study where, it's possible that because of those differences, whether it be blood pressure or a certain lab test, it's important to understand whether or not that makes a big difference, but then also to recognize that if this treatment is not going to be, most efficient or available for those who don't fall within those certain guidelines for the clinical trials, then what needs to be done to address these issues for those whose original baseline is not the same as others. So by really focusing on a certain set of numbers when doing the clinical trials, it can really lead to a form of bias or discrimination within those clinical trials. It may not be intentional, but that's where having these retraining or re-education meetings and classes are really important. And this actually, I found this out and actually started to do a little bit of research about it after watching a television show that was based in a hospital. I don't want to say the name of the show, but it's not the one that has been on for like 17 years or so. That one actually had my illness on it last year, and of course my DVR didn't record, and I couldn't find it on demand. But it was on one of the shows, and it was about a clinical trial where this gentleman did not fall within those guidelines, even though he desperately did need a different treatment. He was terminal. If he didn't get a treatment, it was, pretty sure that he would pass away, whereas at least a trial would give him a chance. But without falling into those baselines, he was rejected, and that's when one of the nurses brought up the fact that, the baseline for African American males was different than it was for white males. So that needed to be taken into consideration. So I'm glad that it's being brought to the forefront because, it's not something I would have ever thought of. But even going further, just by coincidence, I was watching just it was like a YouTube thing that was playing in the background while I was writing up and doing some research. And one of the facts just from out of the blue was that women were not required to be part of clinical trials until the year 2016. And, here we are. We're 2021 now, so it's only 5 years that it's been required for women to be an actual part of a clinical trial. Now, we've gone over how, women have different responses to heart attacks than men usually. So now it's finding out that, okay, up until very, very recently, it was not even necessary to include women in these trials. Now, maybe looking at this as through the lens of someone who has a chronic and rare illness, I try to see the bigger picture in that. And my thoughts would be, well, wouldn't you be having clinical trials where everybody is represented so you have a good idea of how each person may or may not react to the medication, not only on an individual basis, but see if there are other key factors, whether it's based on race, gender, if there's another underlying illness possibly that some people share where, the medication then has a different effect for them than others. Really, that's why we have these clinical trials, is to look at the effectiveness of the medications and treatments, as well as see, what may be happening on the perimeter, what type of reactions are happening. Is there anything that can be deemed dangerous? And if so, is it happening within a certain group of people that have this commonality? Without having everybody represented, there's no way to ever get those numbers correct. Now, looking through an article of the Pharmaceutical Journal, and this is from 2020, this is one that's talking primarily about sex and gender in clinical trials. we know that men and women respond differently to diseases, but this was actually first noticed by Hippocrates more than 2,000 years ago. And so many times also, women have different responses to the medicine used to treat different things. But even regardless of all of this, women were not in a lot of clinical trials. And now, kind of going to a specific example, and I was not around when this whole situation happened, but when I heard it mentioned one time, I asked my mother what it meant. I was actually listening to a Billy Joel song, and there's a line that says, "Children of thalidomide." And that's just the way he pronounces it. I'm not sure if I'm pronouncing it correctly. But what that was is in the 1960s, there was this medicine called thalidomide, and it was really widely touted at that time. So first, believe it or not, one of the main reasons that women were not included in a lot of trials was because it was thought, especially, with their hormones fluctuating monthly. Yes, I read an article that said that. The person who said that wasn't condoning it. She was just explaining why people thought that way, that women shouldn't be in the clinical trials. So it was looked at that, okay, women have these fluctuating hormones. So to have them as part of a trial to look at what the quote unquote normal is would actually cause more problems than good. Okay, fast forward to thalidomide, and it was being used to treat nausea in pregnant women. Unfortunately, thalidomide caused horrible, horrible defects. And the types of abnormalities in newborn babies, just the list is so wide, we can't even really get into it, but it was consistent. Most women who took thalidomide had a baby that had some type of abnormality or challenge that they would need to face for the rest of their lives. So upon further research, it was just determined, okay, thalidomide is banned pretty much everywhere. But more recently, it has been seen as a way to treat leprosy. And though that's not something we see here in the United States often, there are some countries that do have leprosy as a concern. It also is starting to be used in the oncological field and treating multiple myeloma. So this is a very good example of why you need to have a cross-section of people when doing a clinical trial. In this case, it was more regarding women, especially in their reproductive years, and what a medication could do. So it really set this medication back years because nobody wanted to touch the medication. But, moving forward, it is found that it actually has, some value to it. It's just knowing what its limitations and what its negative effects are before actually going out and touting it as the next miracle drug. So this did set forth, though, the understanding that women should be included in clinical trials. It just unfortunately was not required until the year 2016. Now, there were some numbers about the disparities in the number of people who, are within these clinical trials. Like what percentage of different races participate in the trials compared to what the actual population percentage is. And going to a report from the FDA, and these numbers are from 2018, they took a look at what the actual population makeup is throughout the United States. And for the sake of their study and what was reported in this article, they did focus more on African Americans, Hispanic, and white populations. So whites make up about 67%, so that's just around 2/3 of the population. And within clinical trials, though, about 83% of the research participants were white. So that's a big difference. You would expect to maybe see a 1 or 2, percentage difference. It just, you're never going to get an exact average on that, but you wouldn't expect to see a huge significant difference. But that is a 16% difference, much larger than that should be. When looking at the Black and African American who were in clinical trials versus the population, Blacks and African Americans make up about 13.4% of the population, but only made up about 5% of trial participants. So again, this is a huge difference. This is not a 1 point give or take. It's less than half. Less than half of the same percentage, almost getting down to it's only a third of almost. So when we then look at the Hispanic population, that's about 18.1% of the U.S. population, but less than 1% of trial participants. So there's just so much inequality there that there's really a very, very small chance that when doing a clinical trial that you would get an outcome that is representative of each race. And then also it did not give the breakdown of, sex within there, but it would be interesting too to see the difference between the numbers of males and females, and those should really fall within about, 50% of each. Now, looking at one specific trial on oncology, there were around 5,157 patients in this study. Now, 38% were women, so not exactly half, but as compared to previous years, that was a better number. And 68% were white. And looking at the 67% of the population, that is about where we would expect it to be, 1 or 2% higher or lower, so that it's more representative. 15% were Asian American, which I found interesting that was not mentioned in, that first part that I just went over. But within the same study, there were 4% that were Black or African American and only 4% that were Hispanic. So, that number is even dropping for the African American community, where it's a little bit higher than average for the Hispanic community. So, as far as numbers getting better, it was kind of a mix here that, okay, one was about where you would expect it to be, and one percentage went lower and one went higher. And we have to find a way to make sure that there is a good representation of, every race, each sex, so that we understand how a certain medication is going to affect someone. Now, I know we've all seen medication commercials where it says, don't take if, and it gives like a list of things. So, most medications are not going to be, for everyone. So that even if it's used to treat a certain illness, it may be able to treat many people in that illness who have that illness, but possibly not everyone. And that's why they have those disclaimers that they find through doing a clinical trial. And it's better to find it, during a clinical trial before it's, deemed safe and prescriptions start getting written for it, by the thousands. To better meet the needs of our society, there were goals set to try to make sure that the clinical trials did reflect the diversity of our population. And unfortunately, about 48% of the trials did not meet that goal. So even with that recognition and understanding, and with an effort to try to make sure that all populations were accounted for, it still fell lower than those goals almost half the time. And we have to start looking at why then this might be. Now, the next episode, I will start looking at some of the challenges. And just to give you an idea of what those challenges are, they have to do with income, bias, and medical mistrust, which it's hard that all of the reasons are very hard to take in and to recognize that there are that many shortfalls within our society, but the medical mistrust that some populations have towards the medical field, I mean, it's looking back through history, it's horrible, some of the things that occurred. So that medical mistrust is based on years and years and years of there being some type of bias, and even worse, that occurred within the medical community. And then, just making sure that there's education about, certain health factors, things like that. And something, too, that I've kind of been on from the very beginning that I think I started talking about months ago, when it comes to accessibility, is even just transportation. Whether it's, you have to drive a number of hours to get to where the trial is, or, if you live in, say, a city where you either have to take a cab or mass transit, it's not always as convenient to get to those places. So either way, whether you live in a rural setting or an urban setting, if that clinical trial is not really, really close to where you live, and let's face it, it probably isn't going to be because they're doing research based on a larger number, then not having access to transportation will be a major factor in making sure everybody is represented within the clinical trials. So I am trying to keep these episodes a little bit shorter, just so it's not, say, hours of numbers and all of these things. So what I'm going to try to do is try to stick to one topic per episode, and possibly start to lead into the next topic like we did today. I am trying to do these about once every 2 weeks. Like I said a little bit earlier, I've been having some trouble with some limitations myself dealing with my illness, increased to medications, which unfortunately are not working like I hope they would have. But, I really look at this topic as not something that we want to address. It's something that is necessary. We need to address this because there's no reason why that these types of barriers have not been fixed yet. That it was recognized, even decades ago in some cases, but just nothing was brought forward to try to address those concerns and fix them at that time. So we need to fix them now. We are at the best that we've ever been in terms of communication, accessibility in regards to being able to quickly speak with someone in a different part of the country even. And I use the term quickly kind of loosely because, sometimes you have to leave a message. I guess it depends on who you're calling. But compared to years and years ago, it really is, a better communication, even if you're just sending an email and you know that someone will get back to you. So I know this can be a really tough topic because I know it is hard for me just even looking at the numbers, and I guess looking at it through, just a lens of someone who has more readily available access to certain facts and figures and information about even what a clinical trial is as compared to what I would have known 30 or 40 years ago. So I will leave the sources that I used within the description of the podcast. Now, some of them may lead to links to other topics. So I honestly, that's how I sometimes find a lot of the articles that I end up reviewing and going over. That's because I see something interesting when I'm reading one article and I end up clicking on it and find something else that I want to learn about. So I'll leave all of them in there. There'll be links to other articles that may or may not necessarily be about this, but they're within the same article as a related topic. So, just they're some very interesting reads and can really make someone question things and gain a new perspective. So, I will talk to everybody soon. I will try to get the next episode out at the 2-week mark. If not, just give it an extra day or two. Because, like I said, I'm moving a little bit slower on some things right now. But thank you all for sticking in with this topic. It's a very important one, and I'll talk to you later. Bye.